So we're here to talk about the same concepts we talked about in the last video, which is the concept regarding diagnostics through the work of Dinnar, or Dinar. I'm not 100% sure on how to say the gentleman's name, but it's D-I-N-N-A-R, and again we will link to that within the description. Now, just as a quick refresher, what we're talking about is the fact that there were 5 osteopathic physicians that were essentially observed through diagnostics of multiple patients with lumbar pain or low back pain, and all of the practitioners, even within the multiple patients that they saw, and sometimes within the same patient, they would use different ways to assess the same thing, or assess the same region at least. And one of the things that I'm going to suggest, as I've suggested before, is essentially that the ability to assess something in multiple ways may be a hallmark of osteopathic practice. It may not necessarily be the best for further replication and further study. However, it may be the hallmark in that people believe that they're consistently doing the same thing as far as the motion's concerned, when maybe they aren't. So we just want to take a look at a couple things here. So the patient's in seated, and we're going to talk about motion in the coronal plane. We're going to have the patient in seated, and we'll also have the patient in prone, just as a comparative. But we also want to show how what I'm doing I can say is the same thing, but it may not be. So I'll just have the patient bend this way. So you just get a look at how the patient looks when he bends that way and come back up. Let's do that again just so we can see it again. So bend that. Right. So then we would be able to visually, if we're in the right place and in a palpatory fashion, assess that, whatever it ends up being. Now, we see how the patient can bend in that fashion. I can come here. I can side bend the patient. Now, although it may not graphically look or visually look be easy to tell because I'm in the way, if we look here, right, I think here that I've done the exact same thing as the patient did, but if I come back here, it's not the same. The patient was able to bring himself over here, right? So a lot of times passive testing, if we don't have a good vantage point, we think we're doing something that we're not actually doing, right? Let's have you sit up. So I can use I can use kind of a lean-on approach. So I lean on with my arm, I lean on with my abdomen. I'm able to create some side bending, and I'm able to mostly, in a palpatory sense, through the sense of the body sense or the body contact, as well as through running my hand over the vertebral column, I could get some idea, but I would be missing some of the visual information. The visual information would allow me to confirm what I thought was happening with greater accuracy. So the concept of multisensory integration there. Another thing that I can do, so let's have you put this hand on this shoulder, so I can kind of come underneath and lift and pull, right? Now, in this motion, I can say, oh, well, I'm just going the other way. This is how I'd side bend away from me, create motion in the coronal plane away from me, but this wouldn't be the same. So if we just kind of take a look at that, and what the patient looks like as far as side bending is concerned, and just come down, okay, bend to this side, right? Now, what I want to say is you can see that they're different. What I was able to do to the patient and what the patient was able to do to themselves, they're different things. So my assessment has to, if I'm going to use either one of those motions, whether it be the lean on or kind of walking away from the patient, lifting the patient, I have to admit that the way the patient can move themselves and the way I can passively move them are not the same. So I have to understand before going into using those and trying to make any form of diagnostic judgment or assessment type judgment, I have to admit that what I can do and what the patient can do are not going to be the same things for varying reasons. We can say that they're analogs for one another. We can say that when the patient bends this way, and come on up, or when I bend the patient this way, depending on how I do it. They're analogs to one another. They're similar, but they're not necessarily exactly the same. So the diagnostic value may be somewhat lacking when I do it versus when the patient does it. So the patient active process is quite important. Now, because the patient moves in the coronal plane and I move the patient in the coronal plane and all of these things, I can say that I'm assessing the coronal plane. We understand, we've already pointed to the fact that there's some difference. You're going to be laying on your stomach. So one of the things that's going to happen is that in a different position, things change. So with the concept that the table makes stable, right, the biggest problem in a position such as supine or prone as far as testing the coronal plane is that you have to lift portions of the patient so that there's not as much friction between them and the table. So that contact creates friction, creates a problem with motion. So something that you'll see people do is kind of identify spinous processes, and they'll do glides, right? Now if you look at how far, it's not perfect in this video shot, but I can't move the patient appropriately in the coronal plane here, right? This is sometimes called shingle testing. I can't do it appropriately to approximate when the patient moves themselves. Some people will say, well, then what you can do is you can take one leg. Let's just say I wanted to focus on the lumbar column. I can take a leg and I can do something like this, right? Now, this is hip abduction. Once I get into hip abduction and I continue farther, ideally I should be able to start essentially dragging the pelvis across the table. So I have to go really, 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 really far to start to get to where the lumbar column will stop, right? So I actually have to basically drag the patient across the table. I could do that with both legs, at least it's possible. It's not comfortable, but I can kind of drag here, right? And you can see I can go quite far with the patient, but again, there is the resistance from the table. But I have to do something like this to begin to approximate what the patient is actually able to do. So we're looking again at the fact that in seated and prone, we can create motion in the coronal plane through the vertebral column, but there is limitations, there are problems. So I want to point to the fact that most osteopathic practitioners will have the ability to create motion in one or all planes, in one or all positions, but they're not perfectly equal. And also I want to suggest that when we are assessing, although it may be a hallmark, an observable hallmark of osteopathic practice, where we will test the coronal plane by leaning on the patient, by lifting the patient and seated as we already did, by dragging a leg, dragging both legs, by shingle testing. These are all motions that can be argued to be in the coronal plane, but they're not equal motions. So in saying that, when we are assessing, when we're using motions for assessment, I would suggest that although it's an observable hallmark or currently observable in between osteopathic practitioners, it may be very valuable for us to say that when we test something one way to start, if we're going to test it again to see if something worked, we should test it the exact same way or as close to the same way as possible. Because as an external observer, if I were to test somebody's coronal motion in the lumbar column when they were seated, and then I tested when they were in prone, they would have a very hard time believing that I was doing the same thing. And the reality is I'm not doing the same thing. I'm doing something that's very similar, but it's not the same thing. So although it's observable that we can create certain types of motions or certain analogs for motions in multiple positions in multiple ways, we should not interchange them with one another as proof that we've done something effective, right? The seated test is the seated test. The seated patient active side bending is not equal or is not the same as me creating side bending for the patient. So if I have the patient actively side bend first, I do something, I perform some form of treatment intervention, and then I passively side bend the patient, they are not equal. I should not behave as if they are the same. So again, we can observe people qualitatively in their practice, and we can observably see that people will kind of interchange tests because, well, they're all side bending tests. I would suggest against that. Choose the side bending test you want to use, or whatever test, whatever motion we're talking about. Choose the motion test that you want to choose. When you perform your intervention, use the same one after.